to have you here today. I think there's a lot of discussion these days about non-claims payment data, and it comes up in various contexts. It comes up in the context of APCDs, it comes up in the context of cost growth benchmarking, it comes up in other formats and settings as well. And so we're pleased to have this opportunity to discuss with you today how we understand it and how we're promoting a standardized approach to understanding non-claims payment data and what progress has been made by several people so far. So let me just go ahead and get started. And so my name is Norm Thurston. I'm the Executive Director at NAHDO, the National Association of Health Data Organizations. And I am pleased to have this co-sponsor this webinar with Freedman HealthCare. So Freedman is a longtime partner and sponsor of NAHDO and one of our good friends, and so have been heavily working, people from Freedman have been heavily invested in this project. So at this time, I'm going to introduce, maybe just lay out how the meeting is going to proceed. So first, we will have an in-depth presentation of the standardized approach, and that will be by Vinayak and Janice from Freedman. And Janice, by the way, Janice Bourgault has been serving, is currently and has been serving as the chair of NAHDO's APCD Common Data Layout Committee, which is our attempt at standardizing the way APCDs collect data, and so that's related to this. And she's a recent board member as well. So we're pleased to have Janice here, and then she can introduce Vinayak. After they've concluded their presentation, we're going to have a short presentation by Katie McGraves-Lloyd from HSRI. Or wait, sorry, did I get that wrong, Jade? Katie is from On Point, right?
Yes.
Yes. Like there's too many people for me to keep track of, and they're all my friends. So Katie McGraves-Lloyd from On Point will have an introduction to us as how this is being implemented in a specific case and how that reacts. And then at the end, we will have some state people who've been doing this, who've actually been working with non-claims payment in various formats, to give their reactions to what we've heard and maybe answer a few questions. And so we'll introduce them when we have the panel. So I'm going to turn the time over to Janice Bourgault and Vinayak Sinha from Freedman HealthCare. So Gabrielle, if you could go ahead and get them on screen, however that happens, and then I will catch you all when it's time for the panel.
All right. Hello and welcome everyone to our non-claims payment session today. I'm Janice Bourgault. As Norm mentioned, I'm chair of the non-claims payment work group. And in that capacity, I'm actually stepping in for Charles Hawley from NAHDO as he could not make it today. Gabrielle, could you forward a couple slides, please? And one more. Great, thank you. So about Freedman HealthCare. Freedman HealthCare was established in 2005. It's a focused consulting firm whose mission is to improve healthcare access, affordability, equity, and quality by empowering our clients, who are mostly states. And currently we've worked in more than 30 states, partnering with them to put health data to work to solve complex problems. And in the most recent years, FHC has built on its expertise in health data and multi-sector facilitation to support states' efforts to better understand care delivery and payment. This includes measuring primary care investment and tracking alternative payment model adoption. In this work, the need for a more standardized way to collect non-claims payment data became clear, and that's what brings us to our conversation today. Could you move one more slide? Next slide, please. All right, so to introduce the presenters. So I'll start with myself. Just a little background on me. I have over 14 years working with and supporting APCDs and specialize in data submission guidelines and technical specifications. And I also function as a chair for the APCD's Common Data Layout as well. Joining me today are my colleague, Vinayak Sinha, another senior consultant with Freedman HealthCare. Vinayak has spent the last decade supporting stakeholders in understanding healthcare spending and high-value care. His focus has been on collecting data that informs recommendations to support policy reform with a keen eye on affordability, primary care, and behavioral health. Katie McGraves-Lloyd is joining us from On Point Health Data. She's a principal health data analyst and a thought leader with extensive experience in the healthcare analytics domain, using that experience to partner with clients to offer innovative solutions to complex problems and data challenges. Next slide. So our goals for today will be to discuss the need for the standardized approach to collecting non-claims payment information, provide an overview of the NAHDO non-claims payment national standard layout, which we'll be calling NCP for short, and which was released earlier this year. We'll also be reviewing the expanded framework, which offers standardized categories and subcategories for reporting non-claims payments, and which is also incorporated into the NCP national standard. And then we'll also hear about the state's approaches to implementation. Next slide. So why develop a national standard? First of all, as many of you know, non-claims payment data is not reported in the APCD claim files. These files are used to collect fee-for-service data and does include encounter data for claims paid under a non-fee-for-service payment arrangement like capitation. We are receiving those encounters, but it doesn't include those capitation payments and other non-claims payments. With a growing interest in collecting this data and the lack of a national standard, APCD state initiatives were beginning to create their own technical specifications. So trying to harmonize those non-claims payment data collection efforts across all states. Also, we wanted to ease the data submitter burden, and also to develop specification that focus on both identifying the level of risk assumed by providers and describe the purpose of the payment, which did not exist previously. Next slide. So first, we'll kick right off and get into a little more detail on the national standard and the layout itself. Next slide. So first, I'd like to go over how we got here. So in 2022, both NAHDO and APCD Council received requests to develop the national standard. They convened a work group, and that work group, one of the first tasks that they did was to inventory existing data submission guides from previous states that were already collecting this data, such as Colorado Civic, Oregon, Maine, Massachusetts, and IHA in California that actually had the member level capitation file. From all of these data submission guides, the group inventoried them, tried to simplify some of the layouts, et cetera, and came up with some initial drafts. In 2023, the work group continued to refine the data layout, and the expanded framework came out. And so a decision was made to include the expanded framework in the national standard. In last year's NAHDO conference, the in-person conference in Boston back in August, both the NCP layout and the expanded framework was introduced to a focus group. And during that session, the group was able to respond to questions that came from the focus group and also receive some additional feedback about those layouts. Which brings us to this year, 2024, where beginning of the year, a near final draft was released that incorporated the stakeholder feedback that we heard in Boston. And in February, NAHDO held an open session for review and again gathered some additional feedback. And then the final revision was completed and the NCP layout was released this past April. So a lot of work went into this. Next slide, please. And the NCP work group that worked on this over the last 2.5 years was made up of almost 30 organizations representing state agencies and nonprofit organizations administering APCDs, submitters or insurance carriers, and vendors and consultants. Included in the state APCDs as in the work group were state APCDs that were already collecting NCPD data, and they provided invaluable insight and lessons learned from their experience in collecting this data. Next slide. So the outcome was the NCP file layout, which comprised of 3 files: an annual file, a capitation file, and a pharmacy rebate file, which I'll get into a little more detail in just a second. Next slide, please. But first, I just wanted to show this illustration as far as how the expanded framework was incorporated in the NCP layout. Vinayak will be going through the expanded framework payment categories in more detail, but again, just wanted to note how they are working together. So the expanded framework payment categories are used to report the type of payments being made, and these categories are incorporated in both the annual file and the capitation file. In a couple slides, I'll be showing you an example of exactly what this looks like and how it is paired to enable reporting payments for primary care and behavioral health. Next slide, please. So first, the annual file. So the annual file captures payments made to providers. Both fee-for-service claims and non-claims payments are included in this file. Like I mentioned, it includes the expanded framework payment categories. It allows for the flexibility to be used for both medical and dental payments. And there are columns to be able to capture payments for both primary care and behavioral health specifically. It's summarized at a provider organization or tax ID level, and also by reporting period. Most states currently are collecting it by calendar year, but it does allow that flexibility for reporting periods or multiple years of data collection. It also includes denominator information, so allows for the collection of member counts and member months to help with the analysis and use of this data. Next slide, please. So apologize for the small print, but this is just to provide an example. Not all the columns are included. I just included some of the main columns, again, for illustration purposes as far as what's included in this annual file. So the columns in blue are how the data is summarized. So you could see the data submitter, the reporting period, and the billing provider information. And again, I just included NPI and tax ID here, but it includes billing provider names and other information. The columns in yellow this is where the expanded framework comes in. You can see both the payment category and the payment subcategory. So each record is, as far as reporting payments, is designated by which type of payment category those payments are assigned to. The column in peach, or columns in peach, is your denominator information. Like I said, the member count and member months. And the columns in green are your dollar amounts. So the total amount either paid or allowed. So paid would be for like infrastructure payments, and allowed would be mostly used for your fee-for-service claims. And then member responsibility amounts where that applies. And like I mentioned before, there are columns to be able to report and designate payments made to primary care and behavioral health. Next slide. The next layout is a capitation file. These are report payments that can be attributed specifically to a member, like capitation payments. It also includes member information, or PII, that will allow for linkage back to the APCD data. So you can see how much money or payments were received on behalf of a member in capitation, link it back to the APCD to see the services that they actually received. It's also reported per reporting period, and because capitation payments are made on a more frequent basis than some of the other non-claims payments, it allows for the flexibility to have these reports monthly or on a quarterly basis. And like previously discussed, it also includes the expanded framework, specifically the capitation payment subcategories. Next slide. So this example, because it's member attributed, you could see includes the member identifiers. Again, I just included names here. Like the other example, the columns in blue are how the payments are summarized. So by submitter, by member, by reporting period, and by provider. We've also included the product category codes, which are in sync with what's being included in the APCD-CDL. In yellow is the payment subcategories, and in green is the payment amount. And I just have two examples here as far as being able to report it by quarter and by month. You can see the monthly. Our member here, Isabel Ringing, she has 3 records, one for each month of that quarter for the monthly submissions. Next slide, please. And lastly, the last technical specification is the pharmacy rebate file, which, like the name says, captures pharmacy rebate data. It also is reported per reporting period, most common on a calendar year basis, and it's summarized at the drug level or the NDC level. In the diagram on the bottom right, I included an example of an NDC code. We're only capturing the first 1, 2, 3, 4, 5, 6, 7, 8 or 9 digits and dropping off the last 2, the packaging codes, because we're most interested in the label information and the actual medication or the product code for this reporting. Next slide, please. And here is an example of the pharmacy rebate file. Again, the columns in blue are how it's summarized. So by reporting period, NDC drug code, we have the manufacturer, the name, also included designation of whether the drug is brand versus generic. The peach are denominator file information, so prescription counts and number of members who had those prescriptions. And in green are the dollar amounts, both the total paid for pharmacy and rebates received. And now I'm going to pass it off to Vinayak. We'll go over the expanded framework. Thanks.
Great, thanks, Janice. So we'll take a little bit of a dive into the expanded non-claims payment framework. So we can go ahead to the next slide. As Janice mentioned, the payment arrangement categories and subcategories in the NCP layout we just reviewed are based on the expanded non-claims payment framework, which was developed for the California Department of Healthcare Access and Information, HCI. And today we're actually lucky to have some of our partners from California on our panel later this hour as well. So we look forward to hearing from them. The purpose of the expanded framework was really to capture payments from a payer to a provider in a single framework to support multiple uses, like understanding actual non-claim spending, payment purpose, and the financial risk assumed by the provider. It also updates the millbank categories and subcategories to reflect care delivery in California. Its other really core feature is this ability to crosswalk the millbank categories with HCPLAN, the Healthcare Payment Learning and Action Network. So on our next slide, we talk through some of the different approaches and how the expanded framework differs. So if we could go to the next slide, please. All right, so the millbank approach identifies the purpose of a payment based on some broad categories. And some of the feedback states provided was that more discrete categories maybe could help better understand payments based on actual contracting. And then the Healthcare Payment Learning and Action Network, HCP-LAN approach, identifies the level of risk for a provider that's willing, the level of risk that a provider is willing to take based on a non-claims payment in their contract. This framework's categories lack a little bit of the nuance that's needed to capture actual non-claim spending itself and the payment intent, and instead is focused on the total spending in contracts with a non-claim payment within them. So the expanded framework that we've developed with HCI really seeks to support policymakers and stakeholders evaluate non-claims payments to align with their priorities through nuanced categories and subcategories. It also updates those millbank categories and subcategories to reflect care delivery in California. And its other feature is really to focus on that crosswalk to see how those millbank categories and subcategories as kind of further defined and with a little bit more nuance may track with HCP-LAN. All right, so on our next slide, if we could go there, we really see kind of why and the uses of this expanded framework as developed by HCI and Freedman. And so the framework was designed with a number of uses in mind. We intend that the data collection tools, such as the NCP layout, would be really designed to capture non-claims payments and the portion of total spend, as well as the level of risk that the provider is assuming. So essentially, it would collect data potentially in two ways. The actual amount of the non-claims payment, such as a $5 per member per month fee for care management, and also the total amount associated with the underlying contract to meet some of these different uses. So in the top row here, it would require additional kind of definitional work with stakeholders for those specific service categories, such as primary care or behavioral health. The uses are supported by specifically defined subcategories, such as payments for primary care and behavioral health integration. And then the middle row requires collecting data on the total spend associated with potentially a contract or members or provider organizations. And that spend would be placed in the category furthest along the continuum of financial risk to the provider. So similar to many current APM adoption approaches that use the HCP LAN categories, but with this framework, we have a little bit more detail on the arrangement options. And as we think about that bottom row, insights on movement away from fee-for-service come from understanding the actual non-claim spending, as well as the movement of payment arrangements that include more non-claims payments on the whole, but may still partially be paid for on a fee-for-service basis. So this work is already in action. So on our next slide, we talk a little bit about our first real use of the framework, which is already being used in California, of course. And to wrap up our presentation, Katie from OnPoint will discuss some of those implementation nuances that folks take the NCP layout or the expanded framework, and then kind of have some additional considerations around. So across HCI in California, there are about 4 different efforts related to non-claims payments occurring on parallel tracks. Each have a different purpose or use. The first one is for total healthcare spending and the target associated with that. This work collects data on non-claims payments to quantify the payments as part of total spending. Then it categorizes those payments to answer questions such as what's the purpose of the spending. Essentially, it helps answer the question, what are we buying and does it have high value? For primary care and behavioral health spend, we want to quantify the non-claims dollars used to support those services and better understand the payment structure so we can determine if it will support care delivery goals. For alternative payment models and its adoption, we try to better understand how much risk providers are willing to take on and how many providers or members are within an APM itself, an alternative payment model, and whether there's potentially, improving care delivery value and equity. And then last is the healthcare payments database, which is the state's APCD. And so this will collect some more granular information on non-claim spending to support kind of more granular and additional analyses. So the framework continues to be used in other ways as well. And so on our next slide, what you'll see is, while California implements this framework, as you know, we've been working with NAHDO to include it in the NCP layout now. We also really appreciate support from the Milbank Memorial Fund that recognizes the expanded framework kind of creates a new standard for collecting non-claims payment data, and that it builds on their work. We look forward to kind of continued discussions to incorporate the framework into various state and stakeholder data collection efforts. So on our next slide is another example of how it's currently being used. The expanded framework has actually already been included in a report by Freedman developed for the Milbank Memorial Fund for a standardized methodology to measure clinical behavioral health spending. There are subcategories within the framework, such as payments for integrated behavioral health and primary care and behavioral health capitation that identify non-claims payments for behavioral health. The report also provides a methodology and code set to measure behavioral health spending, and currently in development are technical specifications to accompany the report that provide detail on how to allocate portions of those broader non-claims payment categories to specifically behavioral health. So we're very thankful for the many states on the call that have, and other stakeholders that have really provided a ton of input and feedback along the way, particularly our payer partners as they think about implementing this. So to round up my portion, I wanted to go through the categories on the next few slides. So on this first slide, we're just briefly going to review some of the various categories and subcategories of non-claims payment that are included in the framework. Note that all of them are crosswalked to the HCP LAN to support comparisons across states already collecting the data, as well as with national data. So each of these subcategories are accompanied by detailed definitions that are also in the appendix of this deck that we can share after the webinar. And the subcategories are discrete, so they allow payments from different payers, such as Medicaid, to also be included. They're also designed with the vision of high-value care delivery in the future, such as collecting information on payments to address patients' social needs. While those may not be robust today, we hope that those will be continuing to grow in years to come. On our next slide, you'll see some additional categories. So if we could move to, there we go, thank you. So in these categories, you'll notice that there's a difference between different types of episodic care, for example, in those shared savings options. So in these definitions, you'll see that there's also a requirement that arrangements must be linked to quality and provide meaningful opportunities for shared savings to providers to be included in these categories. And so this is one of the key features of the expanded framework that really provides a little bit additional nuance and provides some more information on the actual arrangements that are being implemented by payers and providers. On our next slide, we see a breakdown of capitation to support the markets in which capitation is particularly prevalent. The subcategories support a more nuanced understanding of the payment intent in a capitated payment. We look forward to hearing and discussing with you all and stakeholders how the expanded framework categories and these definitions could really help support your healthcare priorities. And so now I'll turn it back to Janice to discuss some next steps for the non-claims payment layout at NAHDO. So thanks, Janice.
All right, so next steps. So we have our first version of the NCP layout. So the first step would be for all of you to go access it, and that could be found on NAHDO's website. One of the menu items, I believe, is download data layouts or something like that. Yeah, so you can access that and take a look at it yourself. The second component is to incorporate the NCP layout into the overall common data layout maintenance and update process. And once that happens, the NCP layout will be on the same cadence as the CDL as far as being updated every 2 years, going through the cycle of receiving feedback and data maintenance requests from all of you for future updates. And that's going on right now for the CDL. So I'll put in a plug as far as if anybody has recommendations or data maintenance requests for the CDL, you have 5 days to get them in. The next step, the third step, taking in all of those maintenance requests would inform the next version and any updates we might want for the next version. For example, a contract file that actually, I believe Colorado Civic's already collecting is being considered for incorporation into the next version of the NCP layout. And with that, I will hand it over to Katie to talk about how all this gets implemented.
Great, thanks, Janice. Hey everyone, I'm Katie. I'm excited to talk to you about implementation of the standard. So basically, now that we have a format, let's talk about what we can actually do with the layout and how states can start implementing non-claims collection or augmenting their existing process. We can go to the next slide, please. So as background, at OnPoint, we're actively collecting and working with NCP data from a number of states and consulting with others who are interested in learning more about non-claims data collection. So throughout this process, we've learned with our state partners And we have some suggested general steps, processes, lessons learned that I'll share today. So I'll go into more detail in later slides, but the general process starts with submitter outreach and support. So for example, socializing the categories in the template, hosting webinars, helping submitters understand how to categorize their programs, which leads into documentation. So a data submission guide or frequently asked question document. Then the data collection starts after an initial notice to submitters. Validation is a key step in the collection, especially if it's the submitter's first time submitting the data. This takes significant effort and attention. And then the data is available for reporting. So, whatever the intent for the collection was, for example, like the percent of non-claim spending or other use case. And we can go to the next slide. So these are some key questions to ask before we dig into the process. So for example, what reporting periods will be collected? And related to that, how does the reporting period relate to submitter reconciliation timeline? So let's take an example. Let's say you want to collect calendar year data, like up to calendar year data 2023, and you want to start collecting it in December of 2024. So that's 12 months between December 2023 and December 2024. So that's a 12-month window. But if a particular cost of care arrangement has an 18-month reconciliation period, you're likely going to collect an interim settlement for that final year, not something that's final. So some work we did in one state, we received $0 for submitters' total cost of care reporting because they had an 18-month reconciliation window. There are ways to mitigate this, like for example, OCA is asking for an estimate, but just something to consider. And then next question, are submitters familiar with the state's goals, timeline, and template? So it's important to give submitters enough notice to properly prepare and test files. Are they familiar with the template? For example, how to categorize their specific programs into the framework. We've had several conversations with submitters where we've helped them think through how to categorize a particular program. But I think this shows the importance of, one-on-one submitter support and socializing the template, like in a forum such as a submitter interview. How will submitters be supported in understanding and validating the format? So this could be webinars, this could be office hours, a validations document, which I'll get into more detail later. And then related to that, how will submissions be validated? So what we did for OCA is we created a validations document, and it's helpful in thinking through the scenarios that would cause a file to fail. So for example, looking at the total primary care non-claims dollars and looking at the total non-claims dollars, and we're going to pass the file if the total is greater than the total for primary care, since primary care is a subset of total care. And so, we're putting that validation in a document to help our internal process, but also to give that to submitters so that they know how they're being evaluated and they can be successful. And then lastly, how long does that validation process take? So this is important for thinking about your timeline. There will be iteration, even if you have great documentation, especially if it's the first time. So sort of give time for the validation, resubmission, validating those resubmissions, and maybe to complete the circle a couple more times after that. And we can go to the next slide. So it's kind of thinking about those questions and now in a process. So step one, we socialize the template with the stakeholders, meaning the submitters. So we help facilitate submitter interviews for our client in Minnesota, and we created an interview guide where we presented them with the non-claims categorization and asked them questions about their specific programs, help them think through how that would fit into the framework. This was especially helpful for specific Medicaid programs, but also, we got to ask them some questions that help with the context for the data. So for example, how well are they able to identify primary care spending? And the answer we got most of the time was they don't really know how to do that because they make a payment to a multi-specialty practice. And once they make the payment, they have no idea how the practice allocates that, whether it's to the primary care providers or specialists, et cetera. And so that context is really helpful for us to interpreting the data and thinking about like the reporting and if we needed to do some imputation for reporting primary care. And so step 2, incorporate findings into relevant documentation. So this is about creating those pieces of documentation like a data submission guide, submission instructions, but using what we learned from the submitter interviews. So you could consider creating a frequently asked questions document if there are key themes or questions that emerge from the interviews. 3, this is a required step, providing submitters with the notice. This is about the required time between notifying submitters of a new data collection and the date the data is due. It might be mandated for 60 days, 90 days, et cetera. And then offer consistent submitter support. So, this is like during that window, once you've given the notice and you're waiting for the data, have submitter training webinars, office hours. Consider reaching out to submitters who may need more support. And even you could consider testing submissions with a key submitter in your state. So for example, like a submitter that makes up most of the population, or one that has a lot of non-claims arrangements. And then finally, sorry, I'm still on 5, almost there, yeah. So finally, we receive the non-claims data, that we've worked so hard to classify and validate that it's usable. And so the key step here is to set submitters up for success with, the previously supplied support and like the validations document. As we know with data collection, it's messy and there's still going to be iteration and questions. So just make sure there's plenty of time for that validation loop. Now we can go to the next slide, please. This is an example of the validation document we prepared for OGA. It's longer than this and has other sections. You can see what's put here are just general formatting checks, like for a file to pass. We've also done checks for the individual files. So meaning like a within file validation, and then a section on cross file validation. So meaning like the sum of non-claim spending is identical across the attributed file and the statewide file, for example. And we can go to the next slide. So yeah, I'm just wrapping up. I hope this helps make it real, how to actually start collecting non-claims information in your state or augment what you're already doing. And please reach out with questions. Thank you.
Thank you, all 3 of you, for this fascinating presentation. I think we've been handling the questions in the Q&A as they have come in. But did any of the 3 of you see any of those questions that you wanted to just dig a little deeper into, or are we good to go ahead and move on to our reactors?
I think we're good to go ahead.
All right, let's do that then, and let's go ahead and bring our reactors on screen. So for our reactor panel, we have Alice Aguirre from Civic, we have Karen Hampton from Oregon Health Authority, Margareta Brand from HCI in California, and Wade Yulee also from California. Julia Tremoroli was planning to be with us, but she is doing her civic duty as a juror. So she got called into jury duty. So she was not able to be with us today. So let's go ahead then. I've got a few questions lined up in advance for you. So let me put this one out there first. So if a state uses the expanded framework categories, how can they perform comparisons to alternative payment model adoption nationally or across different states or regions? How does that work? And let me go ahead and guide that towards Wade, if that's okay.
Thanks, Norm. Yeah, I think Vinayak hit on this when he was showing the mapping, but I think it's important to reiterate the mapping to the HCP land categories. So the HCP land, the 1, 2, 3, 4, it's more broad, but it's more established. And for states with less APM activity in their marketplace, they may be just using the HCP land. And states that have more, like California, that has more active capitated landscape, they could use the expanded framework within the state, but still be able to compare to other states using the HCP land crosswalk and compare to those national benchmarks using the HCP landmarks crosswalk. So I'm very glad that crosswalk is included with the framework.
Okay, good. So we've got a question here from somebody that's anonymous, but it was also a question that I had was about pharmacy rebates. And so I think there's multiple ways of asking this question. I was just going to say, like, why is it important that pharmacy rebates be included? Does that make a difference? And has there been any pushback, or would there be pushback from carriers or PBMs reporting that RX rebate data? I don't know. Karen, do you want to take a crack at that? If you don't, that's okay. I can submit that to somebody else as well. But I thought you might have some strong opinions about PBMs and rebates.
Yeah, thanks, Norm. Actually, this is a strong interest in Oregon. And when I came back from Boston last year, we had an internal meeting, and this is the area that had the greatest interest for Oregon Health Authority and for our Department of Consumer and Business Services that regulates the PBMs and has a prescription drug affordability board from the last 3 or 4 years for it. So one of the reasons this is so important to us and getting the information back from it is because of the impact or lack of impact on the member. And the total price goes down, then their co-insurance should also go down and they should be credited for that. However, what we've heard is nobody bothers to track it back that far. And I believe they're going to say, and they have said before, that it's such a small amount by the time you get to the member that it's really not that important. But when you roll all the members up, it's actually a lot of money in the pockets for the PBM and the insurer. So we are interested in knowing just what is going on with that. One of the early things, because we've been talking about pharmacy rebates before, but having a national push and having a standard format will be really beneficial in being able to move this forward. When what we've heard before is, oh, we don't even track it at the drug level. It's like, well, somebody does, because somebody's putting the money out. So we just need to find that pocket of knowledge and make sure it moves forward so it can come to us. But in trying to have the costs be reasonable and trying to see how many of the rebates are going to the insurers and how much is being kept by the PBM, it's something that Oregon has prioritized for a number of years, but been able to move on until now. We've actually got a framework to help us do it.
I'm also going to bring Mary Jo Condon, who's been working with Delaware. And Mary Jo, can you just tell us a little bit about Delaware's experience with PBM and rebating?
Absolutely, Norm. So for the last, I guess, 3 years now, we've supported the Delaware Department of Insurance Office of Value-Based Healthcare Delivery in collecting rebate data at the NDC level. They actually collect directly from the PBMs. And, you know, when we first got started, we honestly didn't know exactly what kind of data we would receive. And the first year we even collected it at the plan sponsor in the NDC level. And so the next year when we said just by NDC, everybody was really happy with us because it was less of a lift. But we've gotten some excellent information from that. And I think one of the high level findings that I would share is that rebates vary greatly by drug and by type of drug. And so if we could just say, you know what, all drugs are about 25% more without a rebate applied than with, it wouldn't be so important to collect the information because we just say, okay, you know, assume it's about 25% less. But for some drugs, it's 70% of the drug's cost is paid back through the rebate. And for others, it's 0. And so I think as we work to really better understand how much how much are drugs costing us in reality, it's really important to know that rebate information. The other quick thing I'll add, and for those of you who read the New York Times this past weekend and the information that they provided on PBMs, another thing to keep in mind as you collect this data is the role of the rebate aggregator. So a lot of large PBMs now have their own rebate aggregators. Those rebates are sort of like skimmed off the top before we ever know about them. And so just more and more complexity, but I still think very worthwhile to collect what we can in this area.
Great, thank you. Next question is for Alice. If the state adopts this new format, what are some ways that a state can ensure that the files actually contain high quality data? This is kind of a different type of data. So how do you know if it's good data or if it's just made up data? What are some things you can do to ensure data quality?
Yeah, no, that's a great question. Part of our validation process is to compare the data submitted for the rebates to the APCD data that we receive from the carriers. So we're able to kind of align what is being reported in those in their drug rebate files to what we have in the APCD. That's one way we can kind of gauge that, yes, there is alignment there. If we find out, and we do it at various levels, so by IPT, reporting year, and we have a 3-year look back. So if we find that for one of those reporting years, something's off between what's being reported on their files and what we've been receiving for claims, we're able to address that with the payers. And you know, a lot of times it can be something was missed in the reporting. There's a difference in the code that they use to pull the data to report it out at. But our validations and a lot of the payers that submit to the Colorado APCD will agree that our validations are definitely a very granular. There's a lot of those resubmissions that are required to make sure that we're getting the best and final numbers from the submitters. So it takes some time. There's some time on both the APM side as well as the drug rebate side. And ours are separated. So our APMs are one file, our drug rebates are another file, but we also collect, somebody alluded to it, the Pharmacy Drug Affordability Board. We introduced that file 2 years ago as an annual file submission, as well as a value-based pharmaceutical contract file. So we've got some additional drug rebate files that we collect in our whole purview of annual submissions. And our validations all speak to the quality of the data.
Thank you. So let's go back to California. So Margareta, how did California go about developing the expanded framework? Who was engaged in the process? You know, how complicated was it for you to get to the point that you are today?
Sure. So in terms of starting with the Office of Healthcare Affordability, so this is a new office that's aimed to look at total spending across California by different healthcare entities, especially starting with payers. So we will be collecting total spending data through the Office of Healthcare Affordability, and then, you know, Wade's team on the healthcare payments database, the all payer claims database, is also collecting non-claims data. So in terms of, as one department, we have 2 large programs who are collecting data from payers on non-claim spending, on alternative payment models, on total healthcare spending. So we really wanted to create a single framework that would work for both our total healthcare spending target program, OCA, the Office of Healthcare Affordability, and our APCD, the healthcare payments database. So we engage kind of stakeholders on both of those sides. So, you know, Wade working with payers and our team working with payers and providers in terms of how could we collect all of this data. So lots of engagement with our payers, lots of engagement with fellow state departments in terms of how they're collecting data. Others in California, such as the Integrated Healthcare Association, in terms of how they're collecting alternative payment model data. So lots of a variety of engagement and kind of lots of iteration to get to the expanded framework and the various subcategories that we have. So we wanted kind of a key piece we wanted to address is all the different types of capitation in California, which is why we kind of found the HCP land categories a little limiting in terms of not capturing all the various types of capitation. So that was one of the key kind of lessons learned from all of our engagement and why we have a variety of capitation subcategories in the expanded framework.
So just before we move on to the next question, could you just explain a little bit more how the framework's comprehensive approach to capitation enhances your understanding of what's going on with non-claims healthcare spending? Why is that comprehensive approach to capitation so critical to making the data useful?
Sure. So I think folks probably know that California has a high prevalence of HMO plans and capitation. So we really just wanted to understand, not just at the high level, like fully integrated delivery system versus global capitation level, but what's underneath, because some payers also pay primary care capitation or behavioral health capitation or, forms of global capitation. So just really wanted to understand under that high level capitation category, what exactly are we talking about? Are we talking about primary care capitation to a provider organization, or are we talking about global capitation to like a healthcare system or something more broad? And Wade, did you want to add anything to that?
Nothing to add. You nailed that one. Yeah.
All right. So my next question is going to be, stay on screen, Wade, because this question is going to be for each of you in order. We know that there are a lot of use cases. That was clear from the presentations. There are a lot of things that you can do and a lot of things that people are doing. But from your personal point of view, what is the highest value use case for what we've been talking about? What's the thing that you think will be the biggest deal from having this available? Well, let's go with Wade, and then Karen, and then Alice, and then back to Margareta.
Well, for me, because I'm APCD first always, it's the total cost of care. We have the paid claims, but proxy pricing for encounters is always not satisfying, and getting the real dollars coming in from capitation is exciting for us to do that total cost of care calculation.
Karen?
So, yeah, for Oregon, I think it's going to be the better understanding of pharmaceuticals. And I want to do a caveat on that, that for the annual payment file, it really looks fantastic. We, of course, have one, and we're going to be, it's not a wall, but it's going to be a really long speed bump. We've already had a lot of success in having our payment arrangement file integrated into, for instance, our Medicaid coordinated care organization contracts. So if we were to change the criteria and the categories, we'd have to change the contracts. So I just want to give that caveat that it's not disrespecting in any way the annual payments file. But as we're finding that more and more people are having to report that they are postponing getting their prescriptions, having a fuller understanding of the pharmacy costs will be essential.
Okay, thank you, Alice.
Thank you. For Colorado, I think it's really been the primary care, our primary care collaborative with the Division of Insurance, seeing how our APM data really informs on that to understand what payers are really focusing on primary care to get a hold of ahead of any severe illnesses. If we can start using it more proactive than being reactive and treating a member when they're halfway down, some kind of a disease, the APM files really, the reporting really informs on the primary care, the use around it, where it's increasing, where it's decreased, and just trying to understand how we can, support some of these payers to increase it, what kind of policy will help with that, and just really get ahead of keeping our Coloradans healthy.
Thank you. Margareta.
I went to the same place Alice did in terms of primary care investment. So in California, we are tasked with measuring primary care investment as a portion of total healthcare spend, and that these nuanced categories in the expanded framework really help us understand the different payment models that are supporting primary care providers and how much non-claims payments are tied to primary care or supporting primary care providers. And then I think just generally more transparency in terms of the types of payment models that are in use by and the types of non-claims payments that payers are using. Because right now, most of our data collection in beyond HPD and by other departments is based on the HCP land framework. So really getting into that more detail will be helpful.
Thank you. And by the way, for our attendees, just so that you'll know, the link to where you can get the NCP data layout, it was posted in the chat. So it's nahdo.org/data layouts, plural. And that's where you can find that one. And also, if you haven't noticed already, in the Q&A, if you click on the answered questions, you can see questions that have come up that have already been answered, and there are several of those that may be interesting. So let's go around one last time and give everybody 1 minute to the most important thing that you learned today that you hadn't necessarily thought about. So was there something that you saw or heard today, or a thought that was triggered in your mind that you hadn't thought about yet? So Wade, I'm going to start with you again. We'll go through the same order.
Well, unfortunately, my mind is very operational. So the thing that I heard about was, yeah, what if they don't know how to assign the payment, the capitation payment to one of these subcategories? What are we going to do? And I think then it'll be just that upper level category. So D instead of D1 or D2. So that's what I was thinking about today.
Okay, thank you. That's very, very important insight. Karen, something that the thought that was triggered in your mind.
I think for me, it really was the value of understanding the subcategories for the capitation, because that is something that is extremely relevant to where the
Go ahead. Karen, we can hear you.
Oh, I'm sorry. I actually said the payment subcategories, and particularly as it relevant of whether it's procedure related or condition related, is something that I hadn't really thought before today about the value that can have in planning resources.
Fantastic, thank you. Alice.
Same thing around the crosswalk and understanding how we would utilize it, implement it, what that would look like with our payers, just understanding what kind of lift it might be, but it's good to have the crosswalk there so we can refer back to it for sure.
Very good. And finally, Margareta.
Sure. I appreciated really hearing Karen and Mary Jo's experience in terms of the pharmacy rebates and the importance of collecting pharmacy data. So I think that is incredibly helpful in an area that we'll need to continue to pay attention to.
Okay, and we do just have a minute or two left, so I'm going to go ask Katie and Janice that same question. Katie, what was there a thought? If you're still with us, was there a thought that was triggered in your mind?
Hey, yeah, I think I just loved hearing the state's perspective and additional detail on the pharmacy rebate reporting as well.
Very good. Thank you, Janice. Something that was triggered in your mind.
Similar to what Katie said, as far as learning about other states' perspectives and experiences. And this is an opportunity for us to all learn from each other and continue to build on these efforts. So.
Very good. Well, thank you, everyone. We are just about at time, and we're going to go ahead and wrap up. So this meeting was recorded. We will make that available on our YouTube channel as soon as we get it processed. So you can go to the NAHDO YouTube channel, NAHDO's YouTube channel. And then there was a question earlier about if the slides will be available. And yes, we will make those available. I will find a place on our website, and then we'll put a link to that and send it out to everybody where they can find access to the slides. So with that, again, thank you all for coming. We are pretty excited. At one point we had over 200 attendees, which is like new territory for us. We're accustomed to numbers that look more like 70. So a number that looks like 200 is fantastic. But I think that just signals the broad interest in this topic and the broad applications that it has. It's not just an APCD topic anymore. It's not just for breakfast anymore. It's not just for APCDs anymore. People are thinking about this in a lot of contexts for a lot of applications. And it's really critical that we all communicate and let each other know what we're doing and what we're working on. So thank you again. And thank you, Gabriella and Mary Jo, for putting this all together. And we will see you again at our next webinar. Thank you, everyone.